Good evening, everyone. We welcome you all to the third week of KSOS PG classroom. Today, we'll be having a case-based discussion from Kottayam Medical College, where the case will be presented by Dr. Vishnu, and we have expert faculty here. Dr. Gopal sir will be introducing the faculty. Gopal sir, please.
Thank you very much, Reena. This is our third PG program. It's a PG classroom in ophthalmology, which KSOS has been conducting. We are planning, bi-weekly case discussions, and in between we will have some investigations. Like we just finished the fields. Next, we will have the fluorescent angiography or OCT or something like that. So that's the way we are going to move forward in this. So we are very fortunate to have Kottayam Medical College today, and Dr. Vishnu Gopal will be presenting a very challenging case. And Dr. Reena Abdul Rasheed, Professor of Ophthalmology in Kottayam Medical College, she will be leading the discussion. And Dr. Biju John, who is HOD of Kollam Government Medical College, he will be also be there in the discussion. And Dr. Jisha Kamalakshi, again Professor from Kottayam Medical College, will be in the discussion. So these three excellent faculty will be taking us through this particular case, an orbital apex syndrome. Over to Dr. Vishnu Gopal. Can we share the presentation and start it without any further ado?
Okay. So, good evening all. Hope you all can see the screen well.
Yes. Yes,
Okay.
Vishnu. We can see.
Okay. So my patient is a 52-year-old female from Kadanetta. She was a housewife. Her presenting complaint is a right side headache for 10 days, drooping of right upper lid for 7 days, and effective vision right eye for 2 days duration. This is the patient. She complains apparently normal patient for 10 days back. She gives a history of right side sudden onset of headache, more around the right eye, associated with multiple episodes of vomiting, with no history of fever or seizures. 3 days later, she noticed a drooping of right upper lid, which is progressively worsening with no diurnal variation or no history of diplopia. After 5 days, she developed a defective vision in the right eye. There is no history of redness, no history of any deviation of angle of mouth, no history of any scalp pain, or no history of any nasal stiffness, epistasis for nasal discharge, no history of any recent weight loss, fatigue, muscle stiffness, tiredness, 2 days even. With a past history, she has history of type 2 diabetes mellitus since 7 years on oral hypoglycemic agents and insulin, and she had a history of right pyelonephrosis with perinephric abscess 4 years back, which is managed surgically, but the cause is not proven yet. No history of any other systemic diseases, no history of any recent viral infections, no history of any previous head and neck surgeries or drug therapies. Family history, there is no relevant family history. Personal history, sleep and appetite normal, bowel and bladder habits are normal, mixed diet, and no addictions.
Okay, Vishnu. So you had a patient, a 52-year-old female who is diabetic and who came with a history of headache, and that is followed by a drooping of the eyelid. And patient later developed defective vision also, right?
Yes.
So you might be having some possibilities in your mind. Headache, diabetic patient, headache, followed by that drooping of the eyelid. What are the probable conditions that you will think of at this stage?
So this patient has a ptosis with defective vision and headache.
Okay, let us think about one by one. This patient initially had a headache and then a drooping of the eyelid.
Yes.
Drooping of the eyelid means what?
Drooping of eyelids means there is a Turner palsy.
No, you cannot say it's a Turner palsy. What you can say is ptosis.
Ptosis.
Drooping of the eyelid means a ptosis. Okay. So it may have different possibilities, is it not?
Yes.
So what is the first possibility? A diabetic patient with some headache, and followed by that, if there is a drooping of the eyelid, maybe a Turner palsy. What could be?
Maybe diabetic mononeuropathy.
Yes, diabetic mononeuropathy is one possibility. Any other thing that you thought of?
Maybe there will be any aneurysms. Diabetic can cause microvascular aneurysms.
Yes, aneurysm, a life-threatening condition could present like this. Anything else? Headache and vomiting, and later the patient is developing. Maybe she might have had previous episodes of headache, vomiting, something like that.
Chance of ophthalmoplegic migraine.
Yes, good. Ophthalmoplegic migraine could be another possibility. Okay. So there are maybe some other possibilities also that you would have considered, right?
Yes.
Okay. So this patient also had some defective vision, is it not?
Yes. Defective vision.
Okay. So could you think of something else at this stage from this history alone?
Maybe there is
headache followed by defective vision. What is the usual? Okay, that is one possibility. Patient will be having what? So if it is posterior scleritis, any other symptom the patient will tell you, or you have to ask specifically if it's a scleritis.
And there will be a pain, severe pain with diplopia.
Diplopia, is it a presenting feature of scleritis? Any scleritis, what would be the complaint of the patient?
Pain and redness.
Pain, anything specific that you would like to ask? Sclera gives insertion to what?
Pain, muscles, pain
yes.
on moving side.
Yes, correct. Pain on ocular movements. Okay, the one is a posterior scleritis. Any other diagnosis that will come to your mind? Headache followed by defective vision. Maybe pain. Patient will say that I had pain on looking up or to the medial side, looking up. Yes, retrobulbar neuritis. Okay. Now you asked about many negative. You presented so many negative points in the history, is it not? So, what was in your mind when you asked about scalp tenderness? Why did you ask that?
There is a possibility of giant cell arteriitis is there, which was the same presenting complaint.
Okay. So at 52 years, do you think giant cell arteritis could be a diagnosis? What is the usual age?
More than 60.
Okay, a little more. Ashwati, giant cell arteritis usually comes above the age of 70. Usually, that is a usual presentation. Okay. Now, you asked about what is the usual problem for us for the ophthalmologist with giant cell arteritis. What is the usual pathology that is occurring in giant cell arteritis?
Arthritic.
Okay. Okay. So patient can present like this in giant cell arteritis also. Okay. So you asked about many other conditions also. Okay, we'll come to that after coming to a proper diagnosis. We'll come to that discussion on that after the proper examination. Okay, we'll proceed with the examination.
Okay. Coming to general and physical examination, patient is well built and nourished with normal general examination, no generalized lymphadenopathy, except there is a swelling in front of neck suggestive of thyroid swelling.
Okay.
Vital signs, pulse rate is 86 per minute with normal characters. BP is 130 over 80 millimeter mercury with normal respiratory rate, and patient is febrile. Coming to
any significance for that pulse rate? Why did you specifically? You just mentioned.
The patient has a thyroid swelling.
Yes, thyroid swelling. BP, any significance in this condition?
There will be an atherosclerosis like conditions that can cause. Hello.
You have a patient with multiple cranial nerve palsies, right? So, what is the significance of BP in such patients?
There will be multiple vessel occlusion, ischemia.
Okay, you mean to say vasculitis?
Vasculitis.
Okay. Okay, continue.
Coming to CNS examination, the higher mental functions are normal with normal conscious and orientation with intelligence and speech is normal. Coming to cranial nerve examination, 2, 3, 4, and 6 cranial nerve exam with the ocular examination. All the cranial nerves are examined separately and are within normal limits.
Okay.
Motor system and sensory system is within normal limits with no signs of meningeal irritation with no cerebellar signs. Cardiovascular system, respiratory system, gastrointestinal system is within normal limits. ENT examination shows normal nasal and oral cavity with no sinus nucleus.
Okay.
Coming to ocular examination, the best corrected visual acuity in the right eye is perception of light with projection of rays inaccurate. Left eye is 6.6. Near vision for left eye is 6. With patient has a normal head posture with a ptosis of right upper lid. Otherwise, the facial symmetry is maintained. The Hirschberg test shows a right exotropia of 10 to 15 degree on primary gaze when passively elevating the right upper lid.
Okay, one second, Vishnu, previous slides. Okay, in spite of that ptosis, why this patient's, did you expect any abnormal head posture when you saw that there is ptosis?
There's a chin elevation.
Okay, why? But you said head posture is normal. What could be the reason?
Because the patient has very poor vision, so the patient does not appreciate any diplopia.
Okay. So Hirschberg test, there is 15 degree exotropia, right eye. Why you did not proceed with a cover test?
Because the poor vision of the patient cannot fix it, so we cannot do a cover test or uncover test.
Yes, that is a prerequisite. The patient should have reasonably vision to fix the target. Okay, to do a cover test. Good. Proceed.
Coming to ptosis evaluation, ptosis evaluation shows a 6 millimeter ptosis with poor levator function right eye.
Why did you say it is 6 millimeters? What was the measurement that you took?
Because the palpable feature height is because the mean margin reflex diameter 1 is minus 1 millimeter. That is
minus 1 means what?
1 millimeter below the apex of cornea.
Where is the normal position of the upper eyelid?
Usually 2 millimeter cover the upper part of cornea.
Okay, lower eyelid?
At the level of the limbus, lower limbus.
Okay. Which muscle elevates the upper eyelid?
Levator palparis superioris and molars muscle.
Okay. So levator function is poor in this patient. How did you test for that?
First, we have to press the brow to eliminate the action of frontalis. Then ask the patient to look down. Then ask the patient to look up. So the difference between that position tells the levator function.
So the excursion of the upper eyelid is measured. Okay. Is there any condition where the ptosis is significant, but the levator function is good?
Usually in senile ptosis, the ptosis is there is ptosis with good levator function.
Okay, you mean an aponeurotic ptosis?
Aponeurotic ptosis.
Is there any other point to diagnose that?
There is a bilateral.
Okay, bilateral. What about the lid crease? Eyelid crease. Is it seen at the normal position?
No, it
Sri Lakshmi?
It's seen high up. It is placed high up in than in English letters.
Okay. Proceed.
So the other examination like lid crease, ice pack, and fatiguability organ test sign is negative in this patient.
Okay, why did you test all this?
Because one possibility is the myasthenia gravis. So these are tests to confirm there is a to confirm the myasthenia gravis.
What is Coggins slit twitch sign?
Coggins twitch sign. Ask the patient to look down for 30 seconds. Then ask the patient to look into primary position. Then we can see a sudden shooting up of right upper lid can be seen. Then it will give back to normal position.
Okay. So ice pack test was negative. Does it mean myasthenia or does it rules out myasthenia?
It rules out myasthenia.
Okay. Why? That means what does that mean? Negative means what?
Negative means there is no improvement in ptosis. Like no ptosis cannot be improved by ice pack test.
Okay. Why does in myasthenia? Why does the ice pack test gives a positive sign or improvement of ptosis?
When you do an ice pack test, we apply cold over the eyelids. So the cold will inhibit the acetylcholine esterase. So more acetylcholine will present in the neuromuscular junction. So it increase the action of muscle.
Will you apply the ice directly, or how do you apply the ice?
Over
the ice cube is directly applied over the eyelid?
No, it's the ice pack. Ice pack is applied.
It should be wrapped in a cloth, or even in a glove. If it's a cloth piece is not available, gauze piece can be used to cover the ice pack, and it can be directly applied. That is better rather than directly applying the ice pack over the eyelid. Okay. Next. So you had a suspicion of myasthenia in this patient.
Yes.
Myasthenia, but what was the point against it being a myasthenia from the history?
The patient does not have any diurnal variation.
Okay. Anything else?
And there is optic nerve involvement, defective vision.
Yes. Defective vision is not a feature of myasthenia. Can't it be due to the ptosis? Did you ask specifically whether the patient is having poor vision on lifting the upper eyelid?
Yes, the patient have defective vision on lifting the upper eyelid.
Okay, and your examination also revealed a very poor vision, so not?
Yes.
Okay. Headache, is it a feature of myasthenia?
Yes, I think it can be.
Headache is a feature? Myasthenia?
Usually not, but it can.
How does it occur, headache? Headache is not a feature of myasthenia. Okay.
Myasthenia is a headache, but headache is not a feature of myasthenia.
Okay, proceed.
Okay, proptometry can be done using exophthalmometer, which is under normal limits. Coming to ocular movements, coming to versions of right eye, it is the levo version, levo elevation, and levo depression has totally, and the dextro depression is totally restricted with minimum restriction of elevation, dextro elevation, dextro version, and dextro depression in the right eye. And this is the picture. And also the versions of left eye is pulled in all directions.
So left eye movements were normal, and right eye almost all the movements were affected. Okay. So what all nerves are affected by the examination of the ocular movements?
Ocular movements.
What are versions?
Versions are binocular movements.
What are vergences?
Vergens are both are binocular movements, but the during movement the pupillary axis is parallel to each other. But in vergens, the axis is not parallel, it is cross, it is divergent.
No, not always. No, not like that. Srilashmi?
Vergens are disconjugate movements.
Conjugate movements are versions.
Conjugate movements are versions. Disconjugate are versions.
Okay. Okay. Next. So you are going to did you check any other movements?
Yes, ma'am. Ductions.
Okay.
Coming to ductions, for right eye there is a total absence of movements of levo adduction and depression, and minimum restriction of abduction, and minus the restriction for elevation. But the patient has intorsion is present for the patient.
What does that mean?
There is a fourth nerve is not affected.
So what is that? What does that arrow mark show? What did you check for?
During the testing for intorsion, usually intorsion is superior oblique is action is the depression in adducted position. But here, due to oculomotor nerve palsy, the patient cannot adduct. So we ask the patient to look downwards. We can look a blood vessel at the limbus, and during downward movement, we can see the rotation of that intorsion of that blood vessel.
Okay. What does that tell you? The fourth nerve is intact. Okay. So what are the nerves that are affected by your examination of ocular motility that you picked up?
3, 6.
Third nerve, sixth nerve. Okay.
Vishnu, did you look for any abnormal eye movements? Involuntary eye movements or voluntary eye movements? Any abnormal eye movements?
No, no abnormal eye movements. No.
You didn't mention. Did you look for it? What will you look for? In a case like this, what you should look for? What abnormal eye movement you should look for?
KSOS.
So, Lakshmi?
In the case of
multiple in the case of paralytic lesion, the saccadic velocity will be lost, whereas in restrictive lesions,
you are dealing with a neurological case, right? Multiple cranial nerve palsy.
nystagmus.
So nystagmus has to be looked into. Is it mentioned?
No.
That is not mentioned. So you should add, there are no abnormal eye movements. No nystagmus. It's an important negative findings when you localize the lesion. Okay.
Suppose a paralytic squint is there for a long time, then what other finding will you look for specifically? Suppose it's a case of third nerve palsy that has been existing for some time. And when the patient is coming for follow-up, what other abnormal movements will be looking for? You will be looking for?
For any aberrant regeneration.
Yes.
And that is for any pseudo-bone sign. That is there's a during patient adduction. There's a widening of palpal fissure. And pseudo-orbital rotation.
On looking down.
On looking down, the upper eyelid is retracted.
Yes. What is the significance of picking up aberrant regeneration on follow-up?
It indicates their previous traumatic injury to the oculomotor nerve.
It can happen in traumatic and
aneurysm.
Any other compressive lesions in general. It need not be aneurysm alone, but it could be a tumor compressing. So compressive lesions and traumatic lesions, you get aberrant regenerations. What is primary aberrant regeneration? What is secondary aberrant regeneration?
Primary aberrant regeneration occurs without any further previous history of any trauma or previous history of any compressive lesion.
Yes. What is the significance? There is no pre-existing nerve palsy. The patient had not gone through a nerve palsy. So what does that tell you?
It's congenital.
Congenital? What were the two conditions that we mentioned right now? Trauma and
compressive lesion.
Yes. You might be dealing with a case of compressive lesion. That is a significance. Okay. Then you said it is nerve palsies. Okay. How do you know that this is not a restrictive strabismus?
Okay. By the examination, there is a deviation.
There are some movement restrictions are there. How do you know whether it is paralytic or restrictive?
By using a force structure test.
Some echo is there.
In paralytic.
Is Vishnu using two devices?
No, madam. No.
Then everybody is in separate rooms, isn't it? Are there people who are in same room?
No, I'm alone.
Okay. Now the voice is clear. Okay. Vishnu, you want to answer?
Yes, yes, ma'am. We can do a force duction test to assess
Okay.
whether restrictive or paralytic. Or force generation test can be done. Then by the deviation of eye is less in case of a restrictive skew, but it is more in case of a paralytic skew.
That is when compared to the extent of the ocular movement restriction, is it not?
Yes.
Okay. Okay. Any other, if you are given a tonometer, will you be able to say something?
Differential tonometer. We can check the intraocular pressure in the primary position and ask the patient to move the eye to the restrictive position, and we can again check the IOP. A difference is more than 6 millimeter.
Okay. Continue. Continuation.
Coming to ductions, ductions of left eye is full in all directions. Coming to untitled examination, right eye shows in severe ptosis with negative navigation sign with non-thyroid eye signs. Orbital margins are intact, no skin changes of internus, non-engorged veins. The conjunctiva, cornea, anterior chamber, and the iris of right eye is normal. Pupil is 4 millimeter round with 1 millimeter anisocoria with sluggish direct and concentric lobulus with grade 2 RAPD. Near lip is absent. With lens is normal and anterior it shows no cells. And the anterior segment is considered left eye is with a normal lens with 3 millimeter round pupil. Lateral reflex is brisk and sluggish concentric reflex. Okay.
So there is a grade 2 RAPD in right eye.
Right eye.
Okay. And patient was having very poor vision in right eye.
Yes, ma'am.
Okay. Suppose what are the reasons, probable reasons for a very poor vision with RAPD?
Maybe an optic neuropathy.
Okay, this patient could be having optic neuropathy. Can it be due to a retinal pathology?
Yes, there will be a retinal detachment.
Okay, suppose the patient's vision was a little more, somewhat better, maybe 618 or so. What other tests would have differentiated the retinal cause from an optic nerve disease?
Color vision.
What are the other functional, functional visual parameters that you will look for? Color vision. Okay. How does it differentiate the two?
Color vision is normal in retinal pathology, but will be defective in optic nerve pathology.
Okay. Any other visual, any other functional parameter that you would like to assess?
Visual field.
Okay. Then
contrast sensitivity.
Yes, contrast sensitivity. Okay. So, if do you think the pupillary examination finding, all the findings can be explained because of the optic nerve or retinal involvement alone?
No, there's a mild anisocoria is there, so there will be some internal ophthalmoplegia is there.
Okay. So, can a unilateral optic nerve disease produce anisocoria? Suppose patient is having optic nerve disease in right eye alone, will that patient be having an anisocoria?
No.
Yes or no?
No.
No.
Sure. Sri Lakshmi? Unilateral optic nerve disease, will it produce anisocoria?
No. Optic nerve disease won't cause anisocoria.
Can't hear. Can you repeat, Sri Lakshmi?
Optic nerve. Is the optic nerve does not cause anisocoria?
Unilateral optic nerve disease will not produce anisocoria. So there is something else. 1 millimeter, can it be physiological?
It can be.
Okay. So if it is physiological, that direct reaction, will it be brisk or sluggish?
It will be brisk.
Okay. Okay. Proceed.
So the coming to fundus examination using tropic camera and fingerprint and indirect ophthalmoscope and 3D lens. Right eye shows a media clear with normal optic disc margin with no hyperemia, and cup disc ratio is approximately 0.3 with neuroretinal is pink, and the vessels show is normal with no vessel wall sheathing or toxicity. Surrounding retina is normal. Macula shows a few macroaneurysm and few dot hemorrhages temporal to fovea with dull foveal reflex. And fundus examination of left eye is also media clear with normal optic disc with no hyperemia or blood disc margin. Cup disc ratio is 0.3 with neuroretinal is pink. Surrounded retina is normal with results shows no vessel wall sheathing or normal. Macula shows a hard exudates, few hard exudates supratemporal to fovea, and macroaneurysm is there temporal to fovea with dull foveal reflex.
So that means, could you explain the poor vision because of the by your fundus examination?
No, there is nothing.
Did you pick up anything?
There is nothing in the fundus to process the for the vision, defective vision.
Okay. What all things did you specifically look for? What all did you expect when you examined the fundus in this patient?
For this, there is a RPD in this patient. We imagine a optic nerve pathology. So for any optic disc edema, there's a blood building of dismarking or optic disc hyperemia or optic atrophy or presence of any
optic atrophy. Will it set it so soon?
No, ma'am. It is not so sudden. Or presence of any choroidal folds.
Acute. You expected some choroidal folds, some disc edema. Okay. Anything else that you expected in the fundus?
Any presence of any vasculitis is there.
Vasculitis, a simple vasculitis alone, will it produce this much of poor vision, perception, light only?
No. Something.
Vasculitis could have produced what?
Vascular occlusion.
Vascular occlusions. Okay. Okay, next slide.
Coming to objective refraction done using tropic camera and fingerprint using streak retinoscope at 2/3 meter distance, suggestive of a compound hypermetrophic astigmatism against the rule.
Okay.
The intraocular pressure measured by applanation tonometer at 11 a.m. Right eye is 70 mm of mercury, left eye is 80 mm of mercury. Color vision could not be assessed in right eye due to poor vision. Left eye is normal, and visual field evaluation of left eye by confrontation is full.
Okay.
Coming to summary, a 52-year-old female known case of typhoid diabetes mellitus came with complaints of sudden onset of right-sided headache for 10 days, followed by drooping of right upper lid and loss of vision right eye. Her best corrected visual acuity is perception of lid with inaccurate projection of rays in the right eye and 6 in left eye. And there is a total of ophthalmoplegia in right eye except intorsion with optic neuropathy right eye. Contact examination shows normal optic disc. So the clinical diagnosis is a total ophthalmoplegia with posterior optic neuropathy right eye, probably optic orbital apex syndrome with mild NPDR both eye and type 2 diabetes mellitus.
Okay, Vishnu.
Regarding that 5-1 part, I think, I mean, I didn't hear about the what I mentioned, the corneal sensation and all. I think I must have missed that.
Corneal sensation is decreased.
Okay. So that is mentioned. Corneal sensation and corneal reflex. Reflex was also tested.
Yes, reflex is corneal reflex is also decreased.
So corneal sensation and corneal reflex is decreased in the right eye.
Right eye.
Okay, normal left eye, isn't it?
Normal left eye.
Okay, so that is why you said 5-1. Okay. Yeah, I mean, so this is finished, isn't it?
Yes.
Yes.
Then maybe we can just stop the screen share. Are there any more slides? No.
No, sir.
Okay, then I think can't we stop the screen share?
Okay.
And what about the Other cranial nerves also, I mean, you showed a slide, but I think it was moved very fast, so I couldn't actually read it. Is there any other cranial nerves which is significant? Any other part of any other examination which is important here?
The trigeminal nerve is important, sir. The first division, second division, third division. We can look for the corneal the sensation of face, and also the facial nerve for any facial nerve abnormality.
Okay, so 5-1 you said. So how did you look for the 5-2?
5-2 look for any sensation in the maxillary area and sensation and.
So that was also done.
No, it's normal, sir.
Normal. So I think that has to be mentioned specifically because why is it important? Why we are actually looking forward for this 5-1, 5-2? Why is the 5-1 and 5-2 important here?
Because we have to localize the lesion.
How is it going to help in localizing the lesion?
Since the case of optic neuropathy with defective vision, somewhere in the orbit or in the cavernous sinus is there. If it is in the
orbit or the cavernous sinus, not in between. Why are you going to the orbit?
Orbit means
can it be in the orbit?
Yes, the orbit in the posterior part of the orbit, maybe.
Yeah, what is the name of that posterior part of the orbit?
Maybe orbital apex or supraorbital.
Orbital apex. Yeah, just for argument's sake, I mean, can it be possible that this patient has got an orbital lesion because the orbital tumors can also sometimes involve the optic nerve and the third nerve. So is that possible? Just for argument's sake, because in neuro-ophthalmology, I think localization is important, so you need to consider all the aspects. So let us start with the orbit.
If it is in the orbit, to affect this much of 3 and 6 nerve, it will be a large lesion. So there will be a proptosis there. But this patient does not have any proptosis.
Okay. So even with proptosis, I think you must have seen the orbital lesions. No, they are usually producing patchy involvement. You don't get a complete involvement of the entire third nerve and this thing like that. So one or two muscles will be spared, and invariably there will be proptosis. So that is how you rule out orbit. Now then you come to the orbital apex, isn't it? That is why probably you are localizing this. So why are you localizing this in the orbital apex, and how did the 5-1 and 5-2 help you with that?
If it in the this patient has a Turner palsy involved third nerve, sixth nerve, and an optic nerve is involved, and only the first division of trigeminal nerve is involved. So it will be more likely in the orbital apex. But if in the cavernous sinus, the second division, or in the anterior cavernous, or in the posterior cavernous, maybe the third division is also affected.
Okay, suppose the second division is also involved, you'll probably localize it in which part?
The cavernous sinus, anterior cavernous sinus.
Yeah, so that is why I think because everybody need to be very, have this in mind. The optic nerve and the 5-1 and 5-2 is probably what is going to help you in localizing into these three parts: the orbital apex, the anterior cavernous sinus, and the middle cavernous sinus. So that is why the 5-2 you need to mention, along with your presentation. Now, so in the orbital apex, there are also some other nerves. You've got your lacrimal frontal trochlear also. That are also coming through there. So in that case, why are they spared? If it is an orbital apex, why aren't they involved?
Maybe the annulus is must be involved.
Yeah, okay. So I think what you can see here is that the structures which are right in the center, just going through that annulus of Zinn, which are the structures going through that central portion of the supraorbital fissure entering the orbital apex, which is sort of circumscribed by the annulus of Zinn. Which are those structures?
Okay, sir. The superior and inferior division of ocular motor nerve, the nasociliary nerve, the sympathetic plexus, the abducens nerve, also the optic foramen is there, optic nerve and the ophthalmic arteries.
Yeah, okay. So the sparing of the other things which are outside is quite well known. So that is okay. Yeah. Then again, because you in your presentation you took so much care to rule out the myasthenia. I think that was the right thing. You're thinking of the myopathies also. So which is very important because these myopathies can present with innumerable combinations affecting number of muscles, which will confuse us a lot. So one of the myopathy which you ruled out was myasthenia. So what about the other myopathies? I mean, is thyroid a possibility here? I mean, there's a thyroid swelling. It can produce compressive optic neuropathy. It can involve the optic nerve. So is that a possibility?
No, sir, but there is no thyroid eye signs. Lid signs is there. There is ptosis is there, and with no proptosis.
Okay, so I mean, and one more thing, what else? You did something like, thyroid can involve this orbit where it can produce this neuropathies in two different stages. In the congestive stage, probably it will be you will have the proptos and all those. In the other stage, the restrictive, that will be picked up by your other test which you mentioned, your force reduction test. Those are all negative, isn't it?
Yes.
You mentioned that. So that also I think you should mention. And thyroid, I think involved, it has got a particular pattern. Yeah, so probably you can about that. What about something like CPEO? It can produce sometimes a frozen orbit. No, sometimes the patient will come with a frozen orbit which doesn't move that side or this side.
It's a chronic disease. It's an acute onset disease.
Yeah, so that is chronic. Then
it's a progressive.
Progressive.
It's a progressive.
Yeah, some of the points you might have already mentioned, but again you'll have to repeat that. For example, the optic nerve.
Optic nerve is not involved.
Yeah, so that I think you need to. I mean, some of these questions, the examiners when they repeat it, I think even if something which you have mentioned earlier, you might have to repeat that again because there is a combination which works here. So generally, that vision will not be affected in a drastic manner like this. And what is the other thing? Another important thing is that which side is involved in CPEO?
Lakshmi.
Anybody else? Sri Lakshmi. Which side is involved in CPEO? Is it a unilateral condition or is it a bilateral condition or?
Bilateral condition.
Yeah, it's bilateral condition.
Symmetrical.
So generally it appears symmetrical. So that is one sort of distinction between your myasthenia and this thing. It's generally comes symmetrical. Okay, so probably again, as you rightly said, you have ruled out the myopathy, you can rule out the orbital lesion. Now you have generally localized in the orbital apex, which fits into your with your picture. Now, what was the importance of looking for the visual field? Because visual field is not possible in the affect eye. So you probably did the visual field in the other eye. What was the significance? If you're looking at an orbital apex, why is it important here?
If there is any cavernous sinus lesion, it may compress the pituitary optic chiasma. So it will produce a defect, visual defect in another eye.
Yeah, but in such a case, it will not produce a total loss of vision in one eye, wouldn't it? Will it? Okay, let me tell you. I mean, same case, when you looked at the confrontation field in the other eye is having a supratemporal quadrantic defect, which is sort of, restricted by the midline. So that is the field defect in the other eye, a supratemporal quadrantic defect. And this eye, it is the same thing, same presentation. Now, will you think of any possibility, any other possibility? So I'm just giving you a scenario. Sri Lakshmi?
It can be junction scotoma produced by compression in the optic chiasma by the pituitary adenoma.
But then pituitary adenoma will not produce a total loss of vision in one eye, will it?
Yes.
And will it produce a sudden loss of vision like this? A sudden patient coming with a painful ophthalmoplegia, headache. Just don't be discouraged. Just because I'm asking you, you might be right. Don't immediately say no.
Pituitary apoplexy.
Yes.
Pituitary apoplexy, how does it present? So pituitary apoplexy can present with headache, vomiting. Yeah, but for it to produce a total loss of vision in one eye and a scotoma like this, you might have a post-fixed chiasma. Okay, so that is possible. So when you have something like that, this is possible. So that is why the visual field evaluation or even by the confrontation, the other eye is important. Okay, So when you have got the optic nerve and with this thing, I don't think we can think of any other area other than the orbital apex. Can you have it in the anterior? If you come back here, cavernous sinus, is it possible, Vishnu? With this set of signs, can it be localized to cavernous sinus? Is it possible?
It can be, sir. Maybe in the anterior part of the cavernous sinus, maybe it present like this.
Oh, but how does the vision get affected?
Vision is not much affected like that. Is that there is no optic nerve involvement is.
Yeah, so generally when you have got the optic nerve involvement also like this, it is unlikely to have, once it goes back posteriorly, it gets separated. Okay. So as far as localization wise, it is unlikely that it cannot can go further posteriorly. So just for argument's sake, let us take the optic nerve out of the picture. Okay. So the vision is normal for this patient. The rest of the findings are the same. Now, would you consider the other areas?
Yes, it might be in the cavernous sinus.
So if it is the cavernous sinus, what else will you look for? What else will you need to localize into the cavernous sinus? You already told that, just I'm asking for the benefit of the others. You already told that.
Involvement of second division of trigeminal nerve. You also look for any involvement of sympathetics.
Will you look for involvement of sympathetic in a case like this? You're already having atosis, isn't it? So is there any way by which you can look for the involvement of sympathetic in a case like this?
Look the pupil, we have to assess the pupil. If there is no reaction, if you please does not have any reaction, it can be a sympathetic involvement.
Yeah, so if there is one possibility is, that is why when you have a constellation of symptoms by which you have a hornets in one eye, hornets and a sixth nerve combination, then always you localize it in the cavernous sinus. So you are sympathetic, that thing is good. So I think the PGs must have realized the importance of that the trigeminal nerve and the optic nerve in helping to localize this neuro-ophthalmic lesion. Now, what about posteriorly? What is the posterior to the cavernous sinus? What is the path of the nerves between the brainstem and the cavernous sinus? That is called what? Basilar part, isn't it?
Basilar part.
So is there a possibility of a lesion in the basilar portion producing something like this? Somebody else? Srilashmi madam ചോദിക്കാറുള്ളോ?
Ashwati, Rashmi.
Okay.
Divya.
Okay. So we are just trying to work out the different possibilities. A basilar lesion can produce a lesion like this. The combination. Yeah, you are not talking. You are forgetting the optic nerve. No, you are just taking the optic nerve out of the picture just for the you are proceeding with the discussion.
Is there some aneurysm?
Aneurysms? Or yes. Vishnu?
It can be. It might be able. Sometimes like aneurysms in the posterior communicating artery. Then.
Aneurysm in the posterior communicating artery. How can it produce a sixth nerve palsy? You can only have a third nerve.
Tenor palsy.
Yeah, the sixth nerve is quite far located, quite far from the third nerve. It arises from much lower down. Okay, and it has to ascend up, travel a long way in terms of the brain as far as to reach the cavernous sinus along with the third nerve. So it is well separated. Even the fourth nerve comes a little more closer, but the sixth and the third is separated quite a lot. So is there any basilar lesion which can have a combination of, that is, even take the 3 and 6? Now you can have, it has to be a huge tumor, a huge tumor or something like a tuberculosis, meningitis or something which the patient, so you can say that the patient will be definitely will not be ambulant like this. No, you will be in the ICU. You will be having some other problems. Or it's a large tumor, there will be a lot of other things. No? So that is quite unlikely. Okay. Srilakshmi, what do you say? Okay, let us say 3 and 6, as you said, a pupil involving third nerve palsy. Okay. And there's a 6th nerve palsy also like this. Examination of the fundus, you find a papillary. Would it change your viewing of the constellation? Now, is it possible for a PCOM aneurysm or a mass lesion in that area?
It can possible, sir.
How?
The mass lesion will compress the optic nerve. The raised intracranial, ophthalmotor nerve, and the increase in intracranial tension will cause a compression of the 6th nerve in the tentorial edge.
Yeah, okay, very good. So that's an excellent answer. I mean, that was what we are looking at. So that is the one way by which that sort of a combination is possible. That is why the fundus examination is also important. So there are different ways by which you can. Okay, so that is about the basilar lesion. So usually you don't get a combination like this in the basilar area. Now, what about in the nuclear and the vesicular area? So then you have the nuclear part and the vesicular area. Is it possible? Again, we are not, we are forgetting the optic nerve. Combination of 3 and 6, is it possible in the nuclear area or the vesicular area? You know the nuclear area and vesicular area, you know? I mean, somebody can you take Rashmi, I mean, Rashmi, Ashwadi, Ashwadi, can you tell me about, I mean, where does the, third nerve arise from? Where are the nuclei located? What about the 6th nerve?
Mute.
വിഷ്ണുവിനെ പറയായിരിക്കും നല്ലതല്ലേ?
രശ്മി, ആതിര, എല്ലാരും പോയോ?
Yeah, Srilakshmi, I mean, yes, Srilakshmi, come on.
Third nerve nucleus is present in the level of the superior colliculus. It contains and this is a combination of
midbrain, pons, medulla.
Midbrain at the level of superior colliculus. The nucleus arranged in different levels. That is a ventromedian nucleus, intermediate.
Yeah, okay. We won't go into the details, but I think you should draw the diagram. No, there's a that diagram you could, I mean, keep on drawing repeatedly until you get that into your head. Okay, only then you will know the level at which it arises. So you know that it arises at the midbrain superior colliculus. So directly below that, that will be the 4th nerve at the inferior colliculus level. And where is the 6th nerve? You're muted.
Unmute.
Yes?
Pons.
Yeah, okay. So what do we say? Can we have a lesion involving these two together? Again, it's Vishnu, what do you say?
Such a massive tumor in the brainstem can be.
Yeah, brainstem inside, okay. Massive tumor or massive infarction. Again, that is unlikely. You know, we are not going to get the patient like this. So since it is so far separated, it's unlikely unless you have got a patchy demyelination or something. So again, that is very, very unlikely. Okay, and also when you are considering of these nuclear and vesicular lesion, you know all those syndromes. That also, I think everybody, I mean, examiners are very fond of asking these syndromes. You know the third nerve vesicular syndromes and the 6th nerve vesicular syndromes. Just tell me the few names. I mean, we are not going to details. So, third nerve vesicular syndrome, which means that the vesicular third nerve, while it is exiting from the midbrain, which comes along with some structures of the midbrain, as a result of which there is a combination of signs. What are those?
Third nerve, Weber syndrome.
Okay.
Nasal syndrome, Claude syndrome.
So at least 2 of the syndromes that you should be knowing. You know, I mean, then I have seen the examiners asking these syndromes many a time. The Webers and the Benedicts are their favorites. So at least those 2. And the sixth nerve?
Fowley syndrome.
Yeah, Fowley Millard Gubler. We are not going into the components of all those things, but I think I should be knowing that. Okay. So that is the features of the new vesicular lesions. No vesicular lesion, that will be, it will come along with these things. So that is what you should be telling. You're not seeing any of those combinations. You are seeing the patient which is ambulant. Okay. And nuclear lesions, again, it has got its own sets of specific features. For example, a third nerve nucleus. Can anybody tell me one feature of a third nerve, something you can say that this is a third nerve nucleus which is important? Vishnu?
Patient have a if it is a bilateral LPS.
Okay, bilateral ptosis. Why? Because that, you know the reason, no?
Yes, there will be central central cortical nucleus is there.
Okay, okay, okay. Anything else?
Isolated superior rectus.
Isolated superior rectus palsy. Okay, okay.
It's
So
right.
one right
That's a good
side,
answer, right?
right side superior rectus nucleus is gone. Which side you will get the palsy?
Left side.
Why?
It's the superior, it will cross the crossing there.
Yeah, okay. But practically what we get is it will also be usually be bilateral because the crossing generally takes place very close to nucleus. So the other side also will be generally affected and it's also be bilateral. So these are the some of the specific features of the third nerve. And what about the sixth nerve? Can you just tell me one syndrome which is associated with sixth nerve nucleus?
Fowley syndrome.
No, that is vesiculars. We're talking about nucleus. Because sixth nerve nucleus, what is close to that? You got the gaze center, isn't it? What is that called?
Internuclear ophthalmoplegia.
No, yeah, okay. I mean, before that.
Paramedian bone reticular formation.
Yeah, so I mean, sixth nerve is associated with that. Nucleus generally will be associated with the gaze pulse. Yeah, I mean, so that is where you are all these syndromes come. You know, when you have this, the internuclear INO comes, then you are 1.5 syndrome, 8.5, 15.5, lot of half syndrome. You know? I mean, these people are very, very fond of this because these are very catchy terms. That is why, because I heard people asking about 1.5, I thought they will stop. Then they are asking about 8.5. Then they asked about 15.5. Yeah. So I think it would be probably beyond the scope of this discussion, discuss all those things. But I think you will probably, I think everybody knows the 1.5, the INO and the 1.5 syndrome, isn't it? Yeah. So along with when the seventh nerve is involved, they sort of added that and is calling it the 8.5. Problem with all these fancy terms is that they just sticks on to the examiner's head, you know, and get asked. That's all. Yeah, so that is about the localization. Okay, so as you correctly said, when you have got that is one advantage of neuroophthalmology that you have. You have a certain set of symptoms, you can correctly localize it. So you have what you localize, it is in the orbital apex. I don't think there is any other, I mean, probably there are other possibilities, but unlikely. When you have a constellation of signs like this, it would be probably this. So having localized it in the orbital apex, then how will you go about with the etiology? That you will require the help of the history.
You can do any imaging.
No. Before imaging. You've got a very beautiful history here. No? You've got a 52-year-old patient presenting initially with a headache, which resulted in vomiting. And then there was a march of events. First the patient got the third nerve, then he got the second nerve. So there was a march of events which took, which occurred in a very short span of time. So what does it tell you?
It may be an infective or inflammatory.
Yeah. So possibilities are it could be inflammatory or rapidly progressive infection, or it could be what else?
Vascular lesion.
Okay, vascular lesions. Vascular lesion. Yeah, so these are the way I think you will have to proceed. Now, you will have to think of the individual things in all these things. Any tumor is possible? Other than this, you have talked about inflammatory infective. Is there any mass lesion possible? Because everything points to a compressive effect.
Can be, sir.
What mass lesion? If it is a mass lesion, how does it produce sudden, such a progression of symptoms or the features in such a short span of time?
The mass lesion can directly infiltrate the optic nerve, and also the compression of the vessels can cause vascular occlusion also. So both of these, vascular occlusion and the infiltration, will produce this much of diffusion.
Yeah, I think probably Reena would want to add to that. Generally, when you have something like a tumor producing, you have to suppose have a rapid expansion of the tumor due to some sort of a hemorrhage or something. What is there, Reena?
Yeah, now I will take over.
Yeah.
Okay. Vishnu.
Yes, yes,
Okay. So now you know there was how it happened, like where it is located, and now you should tell me what is it. So you said it can be an inflammation, infection, vascular, neoplastic, all you said. Can it be an infiltrative lesion?
yes, ma'am. It can be.
Instead of a large, huge tumor, can it be an infiltrative tumor?
Yes,
That is also a possibility.
Possible.
So there are so many causes for each of these etiology, right?
Yes.
You can list a long list. So then how will you know what is your patient is having? So whether it is inflammatory, infective, or neoplastic, or vascular, or is a combination, or whatever it is, how do you know that what your patient is having? Then only you can treat the patient or help the patient, right?
Okay.
So what will you do? What is the next step?
We can do further investigations can be done.
Don't say the investigation. What is the specific thing you are going to do in this particular case, and with what in your mind?
We can do an imaging, focusing with possibly MRI can be done with specific cuts at the orbital apex, and look for any enhancements for the level of the orbital apex.
So we'll ask for an orbital apical MRI with contrast. So do you think that it is a disease which is limited to the orbital apex? Are we dealing with a limited disease or an extensive or something which is the diffuse spread? Or is it a part of a systemic disease which we are dealing with? So if that is the manifestation, then an orbital apex imaging alone is enough. Which are the other neighboring structures, lesions involving neighboring structures? Can it spread to the orbital apex?
From the cavernous sinus, it can come to orbital apex, or from the sinuses.
Only cavernous sinus coming to orbit, or other structures?
Sinuses.
Which one is important? Which are the adjacent structures that can produce lesions involving the orbital apex? Ashwati.
Sphenoid sinus.
Sphenoid sinus. Only sphenoid sinus? Any sinonasal disease can spread to the orbital apex, right? So any sinonasal disease can spread to the orbital apex and produce similar manifestations. Need not be sphenoid sinus alone. So if you take an imaging of only the orbital apex, can you get that? So what will be the specific instruction you will give to the radiologist? Because the radiologist will only tell you what you ask for. He said he will ask for contrast enhancement and orbital apex. But I want sinuses also. Do you want brain? Imaging of the brain?
Yes.
So what will be your specific instruction that you are giving? No, you can see the whole thing, right?
We have to suspect a lesion at the orbital apex, so we have to we want to know whether it is the lesion as such and the extent
That
of the
part
lesion.
is done. Now you're instructing Vishnu. Now you're instructing the patient. So what is your instruction? We know that it is involving all these areas as much as cost. Maybe these are the reasons. So what specific imaging you will order? Is it CT? Is it MRI? Is it CT or MRI or both?
MRI.
You prefer an MRI. Why you prefer an MRI in this particular case?
But we get the soft tissue involvement is more easily get in an MRI.
Not only because of that, because optic nerve is the pathology. Vision is so poor. No, it's a serious condition. And we need to know the anatomy and the delineation of optic nerve pathology if there anything that is around the orbital apex, which is a crowded area. So what other additional instructions or additional imaging qualities can help you? You can also ask for a fat suppressed image. That will give you a much more clearer view of the optic nerve pathology. So you need an imaging of MRI of the orbit, brain, and PMS. Because the extensive disease can be from any of these adjacent structures. Now coming to the etiology. Only imaging is needed. Earlier you were saying maybe there is a lesion with a vascular cause. If it is a vascular cause, what else you have to do? What are the common autoimmune vascular diseases that can affect the orbit?
Vaginous granulomatosis.
There is a new name for vaginous, right?
Microangiitis.
No, granulomatosis, polyangiitis.
Polyangiitis.
So, and what else? Any other vasculitis disease which can affect the orbit also?
Sarcoidosis.
Sarcoidosis. And there are so many other small vessel diseases which may be affecting the brain also, right? We don't know. It can be an infiltrative disease or an inflammatory disease affecting small vessels also. So related blood, whatever hematological investigation, that also you have to order. What will you order if you are keeping this as a possibility? Is it a possibility? Can be. It's a possibility higher in the list or lower in the list?
It's a possibility higher in the list.
Why?
There is sudden loss of vision. Is there?
Severe loss of vision.
Severe loss.
Severe loss of vision. And with a normal optic disc. Why? How do you explain this normal optic disc in this case?
Because it is
no
more towards the retrobulbar in origin, more towards the it is posterior neuropathy is there. So the acute onset of posterior neuropathy. So usually the optic nerve under is looking normal.
So you're dealing with an optic nerve infiltration or optic nerve ischemia. Both can happen, right? So if it is optic nerve ischemia, then severe loss of vision can be explained even with a normal fundus. We have done an imaging. And what will you expect in the imaging? Does it tell you whether it is an infiltrative disease or an inflammatory disease or is it a neoplastic disease? Can it tell?
It can be the area of.
Is it possible to differentiate between an infiltrative granulomatous disease or a possible malignant infiltrative disease by doing an imaging? Suppose if it is some neoplastic disease, what are the clinical features you will look for? What are the clinical features, imaging features you will look for in a patient with the infiltrative disease? Like vaginous. What additional finding you can look for in the imaging? Is there anything in your history in this particular patient that you want to review at this stage? Suppose we are dealing with an autoimmune disease, vasculitic kind of disease, granulomatous polyangiitis. Just assume. Is there any point in your history you want to review at this point, which may be contributing to your diagnosis? Is there anything positive in your history? Why this patient had a perinephric abscess and all?
There was a headache. Headache is there.
Headache or no? Is it headache we are talking about? What are the organs that are involved, major organs that are involved in vasculitis? Srilakshmi?
Lungs and renal. Lungs and kidneys.
Suppose we are dealing with the giant vaginous granulomatosis. What are the main organs that are involved?
Lungs and
kidney.
Lungs,
and kidney.
lung, kidney, and
Sinus.
sinonasal disease.
Sinus.
There is sinonasal involvement, right? Right?
Yes, sir.
So there can be ischemia of the nasal cartilage. You can look for those changes in the sinuses. You can look for any evidence of this. Perinephric abscess can be connected to this. We don't know the details. It can be a tuberculous abscess, or it can be something else, or it can be an ischemic necrosis. We don't know any biopsies. We can dig a little bit further into that perinephric abscess if you are suspecting this granulomatosis as a possibility. Can it be a malignant lesion? Can it be a malignant lesion or tumors? Is it possible? Or are we dealing only with a very limited disease? Is it possible to have an extensive disease?
If it is possible, madam.
If it is possible, so then where exactly is the location of the tumor arising from? Which are the structures you, which are the other disciplines which you will send the patient for detailed evaluation? From where the tumor reaches that area, orbital. ENG, which malignancy you are thinking about?
Nasopharyngeal carcinoma.
Nasopharyngeal malignancy is often present to ophthalmologists with this kind of a multiple cranial nerve palsies. Okay, so you have to think about ENG evaluation in detail. And any sinonasal malignancy can also present like this. It can also get into this orbital effects and can produce sudden severe loss with the ophthalmoplegia, all these manifestations. Some distraction is coming from where, I don't know. Can you hear me?
Yes, ma'am.
Okay. So imaging has to be looked into, and in imaging you are looking at any inflammatory lesion or a malignant or a space occupying lesion. Suppose if it is a vascular lesion, as you were saying, like maybe a spread from cavernous sinus or some internal carotid artery aneurysm, that can also have a similar kind of presentation. Then what other additional investigation you may have to do?
We can do
tell me.
We can do an angiogram.
What angiograms? Be specific.
MR angiogram can be.
So after doing an MRI, you can do an MR angiogram if you are suspecting a vascular cause. Okay. Then what about if it is infective one? What are the organisms which you will suspect in that area? And what are the positive findings in your history or negative findings that will exclude the possibility? You have to go back to your history again.
Okay. It may be a fungal infection.
So fungal infection is a possibility in this patient. Which fungus you are suspecting?
Mucormycosis.
Especially in this pandemic season, you have to suspect mucormycosis or a fungal orbital involvement. So
patient is diabetic.
So patient is diabetic, that is a positive possibility. Is there any possibility of a recent viral infection? Did you get any positive history?
No history of any recent viral infection.
No history of any viral infection. Is it Can it be a viral disease that is producing these symptoms and signs?
Herpes zoster can be these symptoms.
Yeah. So history of chickenpox can be asked, and that is something which is important, which can also produce a similar manifestation with multiple cranial nerves, orbital effects. All these can be a possibility. So there is a possibility of a fungal infection. There's a possibility of a viral infection. Do you think it can be a bacteria? No bacteria.
Tuberculosis.
Tuberculosis, mycobacterium can produce this kind of a chronic features in some cases, but acute bacterial infections usually have more intense symptoms and all. So you don't expect an orbital cellulitis producing this kind of a cellulitis due to a bacterial infection. But if your imaging is showing a lot of sinus infection and all, maybe that is also a possibility, especially in cases where there is a chronic sinusitis. But fungal and viral, you have to keep in your mind. Tuberculosis also is a possibility. So if it is a tuberculosis, you can look for other signs of major infiltration, leptomeningeal tubercular nodules, all those things in the imaging. If it is a viral, there can be ischemic necrosis. You can look for small vessel disease or areas of cortical atrophy in the imaging. Or if it is a mucormycosis or something fungal, then you may have to go for a ENG detailed evaluation with endoscopic examination. Okay. So these are the infective conditions which we have to. So infective, inflammatory, neoplastic we have dealt with, and then vascular. Is there anything else you have to keep in your mind? Some not so common causes, but still we have to keep in mind in these kind of cases.
Maybe a pseudotumor.
If suppose this, just for the sake of argument, suppose this patient had history of a sinus surgery or a head trauma some time ago. Can they present like a orbital effect symptom later? Can it occur as a complication of any surgery?
Yes, endoscopic sinus surgery.
So it can be a complication of ENG procedures, or it can be a complication of neurosurgical procedures.
Yes.
Both surgeries can. So if there is a history of an intracranial surgery, head injury, or a sinus surgery, all these are possibilities which you should keep in your mind. So we have listed a lot of conditions. One by one, what do you think is the cause in this particular patient? What can be completely excluded? It is not a post-traumatic case. It's not a post-surgical case. Is it a malignancy? Unlikely or likely?
Less likely. This much of defective vision is?
Defective vision, you can't say. There are so many reasons for an
acute presentation. Is that?
It's acute, and she doesn't give history of any malignancy. It's where in the body. Suppose the patient had a history of CA breast or some CA lung treated some time ago, then maybe malignancy has to be in top in the list. But that is not there. And ENG examination or general examination shows a normal oral cavity. So it's not a very high possible diagnosis, but still we have to keep. Because any metastasis can also produce this kind of a basal brain involvement and can produce manifestations like this. So then we are narrowing down our differential diagnosis to what else?
Infections, infectious and vascular.
Infection or inflammation. So we are dealing with either an infection or an inflammatory condition, which may be a vasculitis. And in a lady, how old is she?
52.
52. So in that age group, is it possible to have an autoimmune vasculitic disease? Yes, it is possible to have an autoimmune vasculitic disease. So if we are dealing with this kind, either of these, infective or inflammation, how do you manage? What treatment you will give? Patient has come to your casualty with extensive manifestations and sudden loss of vision, severe loss of vision. So how will you manage? You have discussed all these things, but you have to give something to the patient for the treatment. What will you give? How do you take the decision?
First, we have to rule out the infections.
We have done. How will you rule out? That is the question. You look at imaging, and these are the things we got.
We got to do a biopsy.
We have narrow down our diagnosis to inflammation or infection. We are not sure. Nobody is sure. Even the imaging cannot tell you whether it is an inflammation or infection. So that is your clinical scenario. So then what will you do for the patient?
We can do a biopsy.
So you will straight away send the patient for biopsy.
Total count, complete blood count.
Huh? All those investigations you have to do. We are doing all those things also. And if you are doing a hemogram, what investigation will tell you that it is infection?
The total count.
Yes, sir.
Total count.
Is it a specific thing?
Yes, sir. CRP.
Neutral.
So, okay, then it is an infection. So what will you treat? How do you know whether it is a fungal infection or a bacterial infection?
Start with the broad spectrum IV antibiotic.
Stelexme is in the casualty and you will start the patient with intravenous antibiotics. Okay. And what will you assess? How will you know whether it is working or not?
If the patient is symptoms that
Do you expect it to be a bacterial disease? Do you expect it to be a bacterial infective disease in this particular case? Very unlikely. So do you think that this is going to help the patient? But still you will give an intravenous antibiotics, but because we don't know what it is. Huh? Nobody is sure. Because it's a therapeutic challenge, not only to you, even to everyone. It is a difficult situation to manage. So if you are narrowing down your diagnosis to and if you are in a position where you can rule out the possibility of an infective etiology, like a fungal etiology, then there is a point in giving systemic steroids under cover of antibiotics to be on to the safer side. Nobody can say that this is purely an infective thing, purely an inflammatory thing, but something which needs a major intervention. Why? Because if it is due to a compartment syndrome or a compression, then it is due to, then that is causing the optic nerve neuropathy and the loss of vision. So you may give a course of systemic steroids depending on the severity. And then you reassess. It's a kind of diagnostic and a therapeutic challenge you are giving. And if the patient shows some kind of an improvement, then maybe you can continue the steroids. Or no? Is it so?
No.
Is it something you can continue, steroids?
No. You taper the steroids.
Suppose if it is a fungal disease, what do steroids do?
It's inflammation.
It will. Suppose it's a neoplastic or a malignant disease. Does steroids help? No. So you assess the response to steroids. Whether it is a good response, excellent response, or a very poor response. If it is not responding at all, by the time you should think about an imaging, by the time you will get an imaging, and also you will do a ENG examination or endoscopic examination. So that is how you can proceed. Otherwise, if nobody can tell you, even the imaging can, unless it is a vascular lesion or a very, very localized tumor kind of lesion, nobody can tell you whether it's an infiltration due to a granulomatous disease or whether it is an infiltration due to some kind of chronic inflammation or a tuberculous disease. Nobody can tell except a pathology. That is the only way to get a definitive diagnosis. So this condition, orbital apex syndrome, is a therapeutic challenge to everyone. How to manage is going to be a difficult situation unless you go for a biopsy. So what is the indication for biopsy? When will you do a biopsy?
If there is no improvement with systemic steroids,
that is why when you give a course of systemic steroids under antibiotic cover and you are reassessing, and if there is no improvement at all, very poor response, or sometimes even worsening can happen, then definitely there is a role for biopsy. And how do you take the biopsy? It's not you who is going to take. It is done by the ENT surgeons. How do you do that? Transsphenoid. Orbital apex, how do you reach? How do you reach the orbital apex? Is it through an open surgery that we are doing these days? Huh? All of you know the surgery. Every day we are sending patients. How do you manage all this? It's not audible.
Functional endoscopic sinus surgery.
So you could do a functional endoscopic sinus surgery, take a biopsy, and wait for the reports. That's the only way to confirm the disease. And you do a surgical debridement of whatever lesion you're saying, and if it is removable, you can remove it. That is the only way to eradicate the disease if it is possible. Then, depending on the histopathology and depending on the report, you can only follow up the disease and follow up the patient and then manage accordingly. If it is coming out as a malignancy, then you have to do address that. If it is coming out as tuberculosis or a granulomatous disease, then you may have to manage like that. If it is a sarcoid granuloma, then you have to manage it like that. Sarcoid is well known to produce optic nerve and optic sheath granulomas and all those things. So in this age group, that is also a possibility. And if it is a vaginous or some kind of a vasculitic disease, you may have to keep immunosuppressive therapy and immunomodulatory therapy depending on the severity. So all these can be done only by a definitive diagnosis which needs a biopsy, which again is a little bit controversial depending on how a patient responds to steroid therapy. Or even if the patient responds to steroid therapy, maybe the patient has to come back. When you keep the patient under the follow-up and they come back with a recurrence, then again you may have to do a biopsy. So if in the primary situation, your steroid therapy is showing some kind of an improvement, which is some a visible kind of improvement, then maybe there is a role in continuing the steroids. Otherwise, there is no role for steroid therapy. You have to have a biopsy and then confirm its histopathology. Gopal is there? It's already 1.5 hours.
Yeah, yes, ma'am. It was an excellent session. Thank you very much for the clinical oriented, the problem oriented discussion, looking at various aspects of orbital apex syndrome, right from clinical diagnosis, clinical differential diagnosis, going through how to reach that localizing that particular area, and then finally discussing that particular case as to how to investigate and manage. It was an absolutely wonderful discussion. The last 1.5 hours had been really useful. I think all the postgraduates, I think we have about close to 200 views. And I think probably over the next couple of days or maybe next week, maybe 500, 600 more postgraduates will view it. And I thank all the postgraduates and from Kottayam Medical College, especially Dr. Vishnu Gopal, who braved it. And thank you, Dr. Reena, Dr. Jisha, Dr. Biju, and Reena. Okay, thank you very much for this. So, how do you